We'll give it about 2 minutes, and then I'll take the screen down, and you can get yours up, Dr. O'Brien.
Sounds good. I still have it on share mode for me.
Okay.
And I have it on share computer sound, so everybody should hear the videos.
Hey, Dr. Sinnott, if you want to start, our attendance is right around 20, and it'll keep building.
I would like to start. I want to welcome everyone to today's Grand Rounds. Today, Dr. Kevin O'Brien, one of our most elegant and distinguished professors and educator of national stature, is going to talk about learner and physician mistreatment, realities and perceptions. Kevin, thank you very much. We're excited to hear you speak.
Right now, right?
Please go to it.
All right. Thank you, Dr. Sinnott. Hello, everybody. I appreciate you joining us during the storm. And let me share my screen. We're good. So we're going to use a lot of different modalities today during the talk. We're actually going to use video, and I'm going to use audience response. And this is a project that I've been involved with for the last almost 20 years. We originally published the work back in 2005, and we called ourselves the PAMS Investigators. And what that stands for is Perceived Abuse of Medical Students. And what we did at the time is we created trigger videos because we were concerned that the literature that's out there on mistreatment was, there's confirmation bias and recall bias. So we wanted to see if we could create trigger videos and watch a group of internal medicine people view these videos and get their perceptions on them. And at the time, the principal investigator of the study was Mike Elnicki, and I said, Mike, we really need to look at the other specialties. I know we're just doing medicine right now, but we really need to look at surgery, OBGYN, psychiatry, et cetera, because I don't think we all think the same. And Mike at the time said, that's too big. Let's just stick with internal medicine. So our original work was published in 2005, and we had 237 people watch the videos from 13 medical schools. Well, we redid the study and just published our results this past year. And this time we had 10 medical schools, many of which were the original participating PAMS investigators, and we had over 1,600 participants. And what I'm going to show you today is the perceptions of the residents and the attendings of those videos. Because what we wanted to find out is, does your specialty influence how you perceive mistreatment? So that's going to be the focus of today's discussion. All right, so we're going to talk about mistreatment. We're going to define it. We're going to discuss its incidence, sites and sources, and the different types of mistreatment. I'm going to talk about reporting, and then I'm going to talk about the consequences. And rather than just sit here and bore you with numbers and data, I'm actually going to show you the videos we used in the study, and I'm going to let you rate them, and then we'll compare you to what our study showed. And the bottom line is, do we all think the same? So here's the definition, and we chose to use the same definition we used back in the original study for our current study. And this differs from the AAMC's definition, but it's very similar. So it's policies, speech, actions, or behaviors that treat a student in an intimidating, threatening, or otherwise inappropriate manner. And the key thing is it adversely affects the student's learning environment. And I think the thing you want to remember is if you think back on your career. Was there ever a time where like you were humiliated on rounds and the rest of the day is blank and you don't remember anything else you did? That would be consistent with mistreatment. So if it adversely affects the student's learning environment. What I tell the students every year before they start third year, because I give them a similar talk to this one, what mistreatment is not. And they need to understand being asked questions on rounds, even when you don't know the answer, that's not mistreatment. Getting negative feedback if you do a subpar performance on a presentation is not mistreatment. Being asked to do something as it relates to the care of a patient on your team, whether it's one you're personally following or someone you're covering for because the intern or resident's not there, that's not mistreatment. And then obviously standing for long periods of time, whether it's in the OR or on rounds, again, that's not mistreatment. So what I'm going to do is ask you guys to participate. And what I'd like you to do is just get out your smartphones, and you could use tablets or a PC. But for smartphones, just text 37607. And then in the text box, put in USF 2019. The USF does not need to be capitalized. If your smartphone capitalizes the first letter, that's fine. Just put no space between the F and the 2. And then once you do that, everybody should get a text that says you're in the poll. So I'm just going to wait a little bit to make sure everybody is in the poll. And and in fact, I'm doing it myself right now just to make sure. And I tested this earlier today. I had no issues with it. Yeah. So I'm in the poll. I think everybody can see that on my phone. Okay. So we'll continue. I'm going to ask you guys a couple of questions. And what's cool about doing this talk on Teams is we have a layer of anonymity now. So I can ask you questions and no one knows who's responding. And I can't identify your numbers. You're not going to get any text charging or anything like that. So just tell me who you are. So we have a lot of residents, we have some students, we have some professional staff, we have some teaching faculty, and we have some program leadership. Okay.
I'm
So
sorry to
residents,
bother you, Kevin.
yes,
My text is not going through. Give me that number again.
it's 37607. 37607. You don't have to put the hyphen. And then in the message box, put USF 2019.
Got it.
And you should get that text.
Thank you.
All right. Okay. Did you get in, Dr. Sinnott?
Not yet. I'm working on it. Keep going.
All right. So were you mistreated in medical school? And again, for those that have not gotten in, you can see the information at the top, so you can text in or join on a tablet or when it said 100%, I was like, whoa. So a little over half of people are saying that they were mistreated in medical school. And that's actually consistent with national data. So USF is falling right in line just with everybody else. So about half of you were mistreated. How were you mistreated? And again, we have this layer of anonymity. So you can put what happened to you and no one knows who you are. And we're actually falling in line with some national data that I'm going to share with you because the most common form is belittlement. And sexual harassment is actually falling. I'll show you some of that data. Racial and gender discrimination is still out there. Scut work is still out there. And thankfully, physical abuse has always been low. And so far, none of the respondents have put it. But when you look at the national data, physical abuse is very uncommon. So we'll keep moving on. Who mistreated you? So the most common, it appears to be attendings for our audience. And I'm not surprised because the biggest group was residents and students. But I'm going to show you some data that'll give you a different flavor as well. Fellow students, I see nurses, patients, course instructor. No one was mistreated by an administrator. Okay. Did you report the episode or event? So only about 20 or so % of people reported it, about a quarter. And we're moving up a little bit, we'll see. And again, USF is falling right in line with the data that's out there that's reported nationally. And I'll share that information with you in a little bit, but we're really much par for the course, no big variations from what's out there nationally. Why did you not report it? And these are straight off the AAMC graduation questionnaire. The only one that is not is choice F. I actually put that one on there because when I've done these sessions, I had faculty members come up to me and tell me when they were a student and resident that they were asked not to report it, which I thought was shocking. So that one is not on the graduation questionnaire. And the biggest respondents are saying that they didn't think anything would be done about it, which is usually what most people say. I love the proactive people that resolve the issue themselves. So let's just give you a background on mistreatment. It's nothing new. It's been reported in the literature since the 1960s, and it's not unique to the United States. And in fact, the 2014 systematic review showed that it's seen in every country in the world. It's not just Japan and New Zealand and the United States. It's every country. And high-income nations, the risk of mistreatment is about 2/3. So 2/3 of students in high-income nations will be subjected to mistreatment or report it, or say they were mistreated, excuse me. And then in low-income nations, they don't do much better. It's about half, okay? So even in low-income nations, it's still occurring. And even though we talk about this all the time, the incidence is not decreasing. And I'm going to share some contemporary data that shows you that 40 to 80% risk of being mistreated. We fell right in that because you guys were in the 60% range saying that you were mistreated in school. And women and minorities are more likely to report they've been mistreated when you look at the literature. So which clinical clerkship do you think has the lowest risk of mistreatment? Dr. Sinnott, you can chime in for the group if you'd like, since your mic is on. And I'll just tell you, it's lowest on family medicine. And internal medicine, we're just like psychiatry and pediatrics, we're right in the middle. And like I tell the medical students, please don't assume that pediatrics they're taking care of happy little people. They mistreat as well, okay? And I like to tell the students, never assume a fish is not a shark until you see how they react when there's blood in the water. And so everybody has the potential to be a mistreater. I'm just going to put that out there right now. And then the highest risks are the surgical specialties. The sources of mistreatment, the most common is actually house staff. Residents and interns, when you look at the literature, are the most likely group to be mistreaters, followed by attendings. But as you guys told us with your responses, nurses, patients, and other students can be mistreaters themselves. And we already talked about these, so I'm not going to spend any time on this slide, but the different types of mistreatment. Here's a study that's from Erica Frank that was published in the early 2000s, and she looked at 16 medical schools across the country. And it was a longitudinal study that was done over 4 years of the curriculum. So they surveyed them every year. And they found that 84% of the students in the class of 2003 from 16 medical schools, and they had 2,800 participants, 84% felt that they were belittled. And belittled is like being made to feel unimportant, that you're not valued. Who do you think was the biggest group causing belittlement? I already alluded to this before. It was residents. Then it's followed by clinical faculty. Then it's patients. Then fellow students, and the preclinical faculty were last. When you look at harassment and everybody sees harassment, they immediately go to sexual harassment. Harassment just essentially means that you repeatedly annoy somebody. So it's like the little brother, if you will. And again, the biggest group for harassment were residents, okay, the biggest group. And second was actually patients, okay? So this is an important group that people are not talking about, and I'm going to show you some data that's going to scare you, okay? Clinical faculty, thankfully, we are a little bit lower, which made me feel better that we came in third. Woo! And then fellow students can harass their classmates, and then preclinical faculty were last. Here's the study that it's going to knock your socks off. And this was in New England Journal of Medicine in 2019. And this is surgery and from the ABSITE, so the American Board of Surgery in Training exam. They gave this survey to every resident that sat for the ABSITE. They had a participation rate of over 7,400 residents. Their participation rate was 99.3%. Fantastic. This is such a great idea to do this. Half the residents in that study, and they were from all 262 programs in the country, half the residents said they were mistreated. And when you broke it down by gender, it was 70% of women said they were mistreated, and 36% of men residents felt that they were mistreated. And then when you break it down into the different types of mistreatment, they looked at gender discrimination, and this is going to scare you, okay? So almost a third of the residents were being discriminated based on their gender, and the biggest perpetrator were patients. And number two was nurses and staff. So we sit here and we give these talks to the students and the residents and the faculty, and we're ignoring the patients and the nursing staff. I think it's important that we get them involved. Verbal or emotional abuse, I think you're already going to predict the biggest group that's doing that is actually the attendings, followed by other residents. Racial discrimination, almost 17%. Here's the scary thing again. It's patients and families. When you looked at verbal or emotional abuse, neither gender was more susceptible to it. Both men and women were subjected to it in equal numbers. The gender discrimination, 65% of the women residents said of those that were mistreated said it was gender-based, 65%, and only 10% of men said that it was gender-based. So a huge discrepancy towards women, and the biggest groups are patients and nurses. When you look at racial, again, it was patients and families, and it was more common in women as compared to men. And then sexual harassment, thankfully, was only 10% in this study. So I think the message is getting out there because I'm going to show you older data about sexual harassment. I think the incidence is declining. But again, the biggest group doing the mistreatment were attendings. And again, it was more likely to be women as compared to men. But there are certain specialties out there where men can actually be mistreated as well. And I'll share you that data in a little bit. Here's another one that's going to shock you, and that was published this year, okay? And this was in JAMA Open. And this was a cross-sectional study that was done at Stanford. And they sent out surveys to 1,800 of their faculty. 1,500 responded. Almost a quarter of their faculty were mistreated, okay? And again, when you break it down by gender, about 31% of women said they were mistreated, women faculty, and about 15% of men said they were mistreated. The biggest group of mistreaters, again, patients, family, and visitors. And you'll note that the numbers are going to add up to greater than 23.4 because they can pick multiple sources. A colleague was second, leadership was third, other staff, and thankfully nurses fell down further on the list here. And I think we work with them every day, and we have to have good working relationship with our nursing staff and our other staff. But again, patients, family, and visitors were the biggest groups. So reporting abuse, you guys, the number was in the 20s. When you look at the national data, about 31% of mistreatment episodes are reported. So the majority are not. So who should report the mistreatment? Anybody who has been subjected to mistreatment themselves or has direct or firsthand knowledge of a mistreatment event. Those are the people that should report. Who must report is people like Dr. Aller, Dr. Sinnott, me, anybody who is in a leadership position. If we fail to report, Dr. Lazam as well, Dr. Rice, if we fail to report, we can actually be fired because we failed to report. So it's very important that when we get a mistreatment event that we take it seriously and we do something about it. And I've worked with residents and students on these. I don't like seeing them, but I have a handful of cases in the last few years that I've reported. And when does an event have to be reported? It has to be reported within 120 days. And so what I tell the students, grades have to be due by 6 weeks after the clerkship ends. So that's 42 days. So what I tell students, they're always worried about grade ramifications, residency selection. I say, wait till grades are in and then let us know. The other thing I tell them to do is type up a Word document when the event happens so it's fresh in your mind, and save that Word document and share it with us after grades are in. So that's what I personally tell students to do. So what are the consequences of abuse? As you guys saw, most of the episodes you described yourselves were minor. Even though they're minor, only 13% are considered severe. It's a major cause of stress for both students, residents, and faculty. And it's kind of scary. There's personal and professional ramifications. For the students, they're more likely to be depressed, anxious, abuse substances, even suicidal. For the residents, they're more likely to become burnt out and have suicidal ideation. For faculty, they're more likely to become burnt out and have what they like to call occupational distress, which means they're unhappy in their job or they're more likely to leave their job in the next 2 years. So it affects everybody. And the more events that occur, the worse those ramifications are. And for students, residents, and faculty, they could have less confidence in their clinical skills. Students and residents may avoid those specialties or reject careers in that field. And this is the sad thing, people leaving medicine. So you already heard me say faculty leaving their positions, but students quitting medicine for good. And with the physician shortage that we're currently proposed to experience, this is not how we're supposed to treat people who are coming up the ranks. So I think the best learning is case-based, and I'm going to show you videos to give you some clinical relevance on the subject, and I'm going to stop with the data. So the first scenario I'll show you is questioning the learner. And just let me know, Jennifer, if you can't hear the sound. I think I have it fixed.
It's good.
And just pay attention to who the actors are.
So my assessment of this patient's left lower extremity swelling is the patient likely has a deep venous thrombosis. We started the patient empirically on heparin, pending the results of a Doppler ultrasound.
And radiology said that the Doppler should be done this morning.
Why do you believe this patient has deep venous thrombosis?
The patient had just taken a long plane flight, and this prolonged period of immobilization probably caused it.
So you're telling me that every person that takes a long airplane flight will develop a DVT. Are there other reasons why this patient may have formed a thrombus? Can you tell me who Virchow was and what his triad is?
I think Virchow's triad is comprised of hypercoagulable states, venous stasis, and endothelial damage.
Okay, good guess. So, is this patient hypercoagulable? And if so, what are the etiologies of this state?
I know there are deficiencies of clotting factors that can do this, but I don't recall them all now.
How do you not know these? Do they not teach those in medical school anymore? How will you be able to appropriately work this patient up if you don't have a basic understanding of these clotting factors? The patient depends upon us to diagnose her and treat her appropriately. You just failed her.
Well, there are a variety of deficiencies, including factor V, Leiden mutation, deficiencies in protein C and S.
Another common cause is antiphospholipid antibody syndrome, and you always have to consider malignancies.
Thank goodness somebody's heard of these. Can you explain the pathophysiology of thrombosis secondary to the lupus anticoagulant?
Well, the clotting cascade involves the intrinsic and extrinsic system. The extrinsic system starts with activated tissue factor, while the intrinsic system starts with activated factor 12. We measured the extrinsic system with the ProTime and the intrinsic system with the PTT. I think the lupus anticoagulant affects the intrinsic system and does something to the PTT.
You missed some very critical points in your explanation. So, what key elements of the cascade did our young, soon-to-be physician fail to mention?
Well, the lupus anticoagulant is not actually an anticoagulant. It binds to the phospholipid to prolong the PTT, which then becomes a procoagulant, which could lead to clots. This case is similar to the one we had last month on our ward team. The patient ended up having lupus with urinary sediment consistent with lupus nephritis. Now, are pulsatile steroids indicated in that case?
I asked the questions here. Let's get back to this case. What do you think is the most likely cause of our patient's hypercoagulable state?
The patient was taking oral contraceptives and had a prolonged period of immobilization.
It's a classic double hit phenomenon described in the literature.
That's interesting. When I talked to a patient this morning before rounds, she denied ever having taken any medication such as oral contraceptives. Did any of you bother to talk to her? Do they not teach you how to take medical histories in school anymore, or is that not part of the curriculum? You all need to take more complete and thorough medical histories. Now let's go see her together.
All right. So I'll ask you guys, does this constitute student abuse or mistreatment? And again, I don't know who you are. You can say it's not. There's no shame. If you think it's not, it's not. So the majority think that it is mistreatment, and about 13% are saying that it's not. How severe is it? Would you say it's low, intermediate, or high? So most people are saying it's intermediate. Low to intermediate would be the majority of people, with most people saying that it's intermediate. Okay. All right. Should it be reported? So about 2/3 are saying yes, about 1/3 are saying no. Not 60-40. Yeah, it's about 60-40. Okay. And to whom should it be reported? Clerkship director, the dean, program director, a resident, the attending himself? So most people are saying keep it at the state level and just let the clerkship director get involved. And some people, small amount, are saying speak to the program director or approach the attending. Okay. And I think it's important that attendings have some self-awareness of their behaviors and what people think about them. So that's part of the reason why during the evaluation feedback sessions I do annually, I give everybody their comments from students, because in those comments, the students might actually write those kinds of behaviors. So I think it's important that you read your comments. So here's what we found with our 2022 update, and this is across the specialties. What I want you to first notice is that we did logistic regression analysis, and we controlled for gender, ethnicity, professional role, and prior mistreatment. And when we controlled for those variables and analyzed it, 3 specialties fell out that said this is not mistreatment as compared to internal medicine. And our biggest group was women who were residents in internal medicine, so we used that group as our comparator. And surgery, OBGYN, and the other group were less likely to say that this was mistreatment than all the other specialties, and it was statistically significant. That other group, who are they? They're actually 74 physicians, 42 of them were residents, 32 were faculty. The majority of them were emergency medicine, about half of them were emergency medicine, and then another quarter or so was neurology and med peds, followed by radiology and anesthesia. So you can see that this other group gives us a good representation other than the 6 specialties we traditionally think of in the 3rd year. And again, when you compared their mean severity rating, and we used a 7-point Likert scale, and why did we do that? We wanted to be consistent with our prior data from back in 2005. And when you go across the specialties, there was actually a statistically significant difference in the mean severity ratings across the specialties. So even though you guys thought this was abuse, different specialties rated it less. And could that impact reporting? Because you guys, about 60% of you said should be reported, 40% said it should not. I'm in the weeds right now of analyzing that data with the current numbers, but I wanted to show you the subgroups. It almost met significance for prior mistreatment here at the bottom, but for the other subgroups, there really wasn't anything close to a 0.05. I'm in the weeds with the current data, so I'm going to show you the older data from our 2005 study. At that time, 76% of the people said it should be reported. And one of the things, I'll call this contrition bias. Usually the perpetrator group feels guilty about what they saw, so they're more likely to report. So in that original work, the attending said, wow, it should be reported. The residents didn't show that difference compared to students. And just like you guys, the majority of people said that it should be kept at the state level and reported to the clerkship director. And it's interesting, we had free text comments at the time. They said that attending was condescending, rude, harsh, abrasive, patronizing, creating an adversarial environment. But I love the bottom quote. Do they not teach attendings how to teach in medical school? Which I just think is hilarious. And other people thought, well, you know, it may not be the best learning environment, but there's lots of pressure there and people are going to be focused and paying attention. And some people thrive in that kind of environment. Okay. I'm going to give you some information now on pimping because I think it's kind of funny and it's great to talk about. Well, the term pimp actually comes from Koch. In the 1700s, he coined the phrase poumfrage, which is pimp questions. And it's really Socratic questioning where people in power ask questions of junior colleagues. The beautiful thing about pimping is that Flexner, back in the early 1900s, when he was observing all the different medical schools, he actually witnessed Osler doing this on rounds, which I think is awesome. And that's why pimping cannot die. It was done by the masters, and if it's done properly, it's going to inspire people. And then there are two types of pimping. We have benign and malignant. And the malignant type we're going to talk about in a little bit, but I still think pimping is important because it promotes interactive discussion. It promotes dialogue. I can figure out what my learners' knowledge gaps are. It keeps them awake, keeps them focused. And I really want to see how they reason through problems. So I like to ask questions. And I think it adds an element of healthy pressure if you do it right. There's an important thing, and I'm a military person and it's Veterans Day tomorrow. Don't break rank. What does that mean? It means when you're the pimper, you should pimp up. So start at the lowest level. If they miss, it's the student, go to the fourth year. Fourth year misses it, go to the intern. Intern misses it, go to the resident. Never pimp down. If you ask a resident a question, it's off the table. No one else is allowed to answer that question. So that's what don't break rank means. For faculty, don't ever pimp one of your colleagues unless you know absolutely for certain they know the answer to that question. Please don't pimp a colleague. Don't do that. And then for students, don't break rank is very important. Only answer the questions you've been asked. And I make that a point to tell the students, don't try to show up your colleague students. Don't try to show up the residents. Demonstrate some humility and don't answer every question. Even if you know the answer, only answer the questions you've been asked. And I think the whole motive with pimping is that you want people to remember the methods and the material. Because if you pimp malignantly, the only thing they're probably going to remember is the method and none of the things that you taught. And as you saw in the scenario, it was a way for him to reinforce hierarchy, and it was more of an ego thing and show students they're not as smart as they think. I want to discuss this just for humor. There are some pimping defense mechanisms. So these are things that I tell students that they can do when they're pimped when they don't know the answer. And the first one is called the eclipser. So what the student can do is strategically place their head behind the head of another colleague so they're not in the line of sight of the attending. They're less likely to be pimped. The camouflager, they look like they're a wallflower. They appear not to breathe or even blink. The meditator, they're going to sit there, hands on their knees, palms together. Please don't pick me. Please don't pick me. Please don't pick me. The muffin approach is a funny one where you have a food item, and right when you know the attending's going to ask a question, you put the food item in your mouth so you can't talk with your mouth full. The hostile response, please don't anyone do this. It's 3 words, monosyllabic, with increasing intonation as you say each one. I don't know. And be sure you won't be asked another PIM question the rest of the rotation, but your evaluation is going to suffer. The one that you can commonly do nowadays is the list. So you're pretending to look at the patient list and you get asked a question and you repeat an answer that's already been said as the attending's going around the room. And you're like, oh, I'm sorry, I was looking at the list. And that will be like your defense mechanism. The honorable surrender is what I tell all the students to do. Say, I don't know. If you don't know the answer, it's the wisest words in medicine. I don't know, followed by, I'll look it up. There's old terms like the politician. You saw the student do it. Instead of answering the question, he asked another question. And then the bluff or the PDA, the personal data assistant, you could be staring at your smartphone. So like you're looking it up on UpToDate as the attending's pimping, so they're less likely to pimp you. But then the other way you can do the bluff is go, well, it hasn't been answered in a randomized controlled trial. You could blame cytokines, or you could quote a higher authority. And an infamous one is like, say, Dr. Altus taught me this, Dr. Ledford, Dr. Lazama, and then the pimper's going to be like, leave them alone, won't ask any more questions. And the one thing I tell students not to do is to sulk or cry. Because I'm telling you right now, we don't remember what questions you get right, what questions you get wrong. But as soon as there's some emotion in the room and it's negative, that we remember that. So please don't sulk or cry. And what I tell students is when there are sharks in the water and you're attacked, don't bleed. If you don't bleed when they attack you, they'll think you're supernatural and they'll stop messing with you. And you'll see attendings when you start to sulk or cry, if they're truly sharks, they'll probably start pimping you more, which you don't want to happen. So whether you agree that this case represented abuse or not, I think you would agree that he was establishing a learning environment. I think he was clearly establishing objectives, and he wanted the residents and the students to take their own personal histories and not just look at the chart or quote what's on Epic, and that he really wanted you to do your own histories and exams. And then finally, I think the key thing with pimping, I'm not going to read this whole slide to you, is that you want to find the right balance in between humiliating the people that you're pimping and boring them to death by giving them all the information. And you got to find the sweet spot in there. And that's why I like to ask questions, because it's not just me droning on and the learners going on screensaver and no longer listening to what I say. Our next scenario is going to be meeting outside of work. Jennifer, you can hear the sound?
Yes, it's good.
So, what rotation do you start next week?
I've got an elective in dermatology. I'm really looking forward to having some weekends off. I've been so busy interviewing, and then I did ER and ICU before this month, so I could really use the break.
Yeah, I know what you mean. You really do need to take advantage of what time you have during your 4th year to enjoy yourself. Besides, a student like you won't have any problem. I'll put in a good word for you.
Thanks. Well, I've got an away elective in Greece in April, so the rest of my year isn't so bad. I just feel like during the last 12 months, I've had no life outside the hospital.
When I was a student, we used to hang out at Zippy's on the weekend. Do students still go there?
Yeah, I've been there a few times after exams during second year. My class seems to have lost touch during the clinical years. Nobody has time for a social life. I don't see how physicians have a relationship if they don't come to medical school engaged or married.
Say, why don't you go with me to the basketball game next weekend? The department gave the residents a block of tickets. Nate and Rosemarie are going to be there. Might be good for you to hang out with some of the people that you're going to be working with next year. Besides, doesn't hurt to get to know the people a little better before the match.
No, I don't think so. I'm really looking forward to having a weekend off.
I understand. It has been a busy month. I'm looking forward to a day off this weekend myself. Well, we better get back to work.
Yes, the video's old.
Hello?
Hey, this is your favorite resident, Kevin.
How are you?
How's dermatology going?
Good. Dr. Chambers is great. I see a lot of rashes and we're still done by 4. You know, I'm beginning to rethink whether I want to be a pulmonologist after all. Too bad it's too late to consider dermatology instead of internal medicine.
You know you're an internist. You would be bored with dermatology within months.
Maybe so. So, what's up?
I just wanted to call and let you know that your patient, Arlene Hawthorne, well, she was discharged today, and you received quite a compliment. She told Dr. Young that you saved her life. I just thought you might want to know.
Well, thank you. What a wonderful thing for her to say.
Well, we already know what a good internist you'll be. Say, what are you doing next weekend?
Well, nothing much. Just finishing up with my rank list.
Why don't you come to Zippy's Friday night? Some other residents will be there.
I don't know.
Ah, come on, you should go. Nate and Rosemarie are going. Could make a difference in how high you're ranked if several of the residents put in a good word for you. Besides, I haven't filled out your evaluation from last month's rotation yet.
You're not saying that if I say no, this will affect my evaluation, are you?
Of course not. I'm kidding. I just thought you might want to go out and have some fun. Get to know some of the people you could be working with for the next 3 years. Well, I better go. Call me if you change your mind. Bye.
Right. So does this constitute abuse or mistreatment? See what the audience says. So about 90-10, give or take. It's about 90-10. How severe is it? Low, intermediate, or high? And so we have more intermediate to highs this time around compared to the last one. But again, most people are, the majority are saying it's intermediate, but it's more intermediate to high when you look at this. Okay. Should it be reported? And unfortunately, let me see if I can reset this. I can't reset this slide. Well, actually, good. It's letting you guys. Should it be reported? It's a moving target. Good. So it's about 2/3 yes, 1/3 no. Okay. It's about 2/3, 1/3. Okay. To whom should it be reported? And I think you can see that people are not afraid to approach residency leadership and even deans for this one, whereas in the first one, most people were keeping it at the clerkship level. Okay. So here's what our study that we just published showed. Again, when we did logistic regression controlling for the gender, their professional role, their prior history of mistreatment and ethnicity, we found no difference between the specialties. So everyone agreed that this was mistreatment. What was interesting, again, when you rated mean severity across the specialties, there was a statistically significant difference in mean severity rating across the specialties. So we didn't all think the same. Even though we agreed this was mistreatment, we didn't rate the severity the same. And that's important because that could have an impact on reporting. And you know, if this person is repeatedly doing this kind of behavior, this is a person that you would really want to know about. And if it's not being reported, nothing's going to be done. And again, when you looked at all the subgroups, there was really no difference. The most common group, as I said before, were Caucasian women that were internal medicine residents. It almost it was starting to go down towards 0.05, but it wasn't there. And then again, we used our older data because I'm in the weeds right now analyzing it. 94% of our original group of 237 people said it should be reported. To whom should it be reported? Kind of like you guys, clerkship director was number one, but they also said dean and program director. And then the interesting thing, of the 8 people that said this shouldn't be reported in our original work, 6 were women. And so what I really think happens is this happens way more than we realize. And the key question of whether you thought this was mistreatment or not was he joking or not? And I'm going to share with you why I think that this was mistreatment in a little bit. And I'll show you on the next slide why I think it was. And I think this resident is less likely to rank the program and want to train there based on her experience. So where did he cross the line? For me, he crossed the line when he coerced her. He did quid pro quo, which is legally actionable gender discrimination. When I use that term quid pro quo, you're like, what the? What it means is I do for you, you do for me. So if you go out with me, I'll get you high on the rank list. If you go out with me, I'll give you a great evaluation. So that's quid pro quo. And that is a Title IX offense right there. Okay. And then the other way it could be is environmental. So if it's a hostile work environment, intimidating, offensive, and the key thing that you need to remember is you have to judge it from the perspective of the receiver of the information. Okay. So it depends on the eyes, ears, and heart of the receiver of that information. And what some people may not consider mistreatment, the receiver of that information may. So you really need to be careful about what you say. When you look at the older literature, 20 to 50% of medical students say that they were sexually harassed. And I showed you that surgical data. Now it's like 10%. Women report it more frequently than men, but men experience it as well. And they typically experience it on OBGYN. And I think we have a big problem in the United States. There's Title IX offenses going on OBGYN right now when men are being excluded by nursing staff and what have you, okay? And sexual harassment definitely influences career choice. And here are the different types of sexual harassment. I think for all of us, you just got to be careful when you discuss music, movies, comedians, because that's where you're going to get in trouble. Excluding someone based on gender, that's a problem too, and it still exists. Unwanted advances, inappropriate touching. And the one that you really need to remember as well is patient harassment. If you dismiss what a patient does, and one of our attendings who shall remain nameless, but his initials are Dan Petter, one of the patients actually accosted one of the students on the team, and he right there on the spot did something about it and said he did not appreciate the language that the patient was using. So I would encourage you, if it's something very egregious, don't dismiss it. Act upon it. And me personally, what I say is, sir, we're a team, and all of the members of the team need to appropriately function to take the best possible care of you. And the comment that you just made is going to affect the morale of the team, and it's going to impact your care. So actually put it back on the patient. Okay. And as you can see on the slide, sexual harassment is least on family medicine and more likely on surgery and OBGYN. And perceptions are critical. Women are more perceptive than us. It's the truth. I think the one thing that I do want to point out is on the next slide, I'm going to skip over this slide for sake of time, is what are your institution's policies on it? I have hot links here, but what about consensual relationships? Can he do what he did? Is there a USF policy on it? And I'm going to simplify the policy for you. Date at your level. If you're a student, date fellow students. If you're a resident, date fellow residents. Don't date above your level. Because when love is going well, when schedules come out, what's the first thing every resident does is look at everybody else's schedule, not their own, to see if there was favoritism going on. And if you're dating the chief resident, they're all going to think you're getting a better schedule because of it. That's true. Number two, when love crashes and burns, and then the next schedule comes out and you don't get what you want, you're going to blame that person for being upset at you, and that's why your schedule is worse. So date at your level, and even better than that, just don't date anybody where you work. That's the simplest thing that you can do, is just don't date where you work. But you can date at your level, and if you decide to date above your level, you have to report it. You actually have to report it, so there's no concern that there's favoritism going on. If you ever experience sexual harassment, what can you do? We actually have a neutral referee, a so-called ombudsman, and that is Olga Skalkos. And when you go to her, she doesn't have to be a mandatory reporter. So that means you can talk to her and there's no ramifications. She can give you great advice on what to do. If you approach me, Dr. Rice, Dr. Lazama, Dr. Aller, Dr. Ledford, anybody in a supervisory role, we are mandatory reporters. We have to report it. So if you're uncertain, you don't think it's a big deal, you don't want to make waves, I would go to Olga Skalkos first, and there's her email. You could also approach leadership, and I put people down there. You can even call the Diversity, Inclusion, and Equal Opportunity Office yourself. You can even use Ethics Point, which is a third-party program, which has no role in USF, and you can report it through them. I can safely tell you, if you get one of these cases ever happen to you and it's reported, like I reported, you're going to get an email from DIEO, and they're going to say, we're sending you this email because the case was reported and the ball is in your court. You can do with it whatever you want. And you can decide that you don't want to report it at all. But as a leader or a supervisor, I have to report it. All right. So after what we've discussed so far, has your perception of mistreatment changed after what we've discussed today? Odd, it's not showing any responses. Let me see if it shows it for me. It's not responding, and I don't know why it's not responding. Hopefully you answered, many of you answered yes, that your perception of mistreatment changed after today's discussion. And I hope that you saw that it's not just students, that it's residents and it's faculty, and big groups of mistreaters are patients and nursing staff. That's an important thing, and ourselves. So here's some additional observation from our PAMS data that we just published this past year. We agree on more serious forms of mistreatment. Sexual harassment, and ethnic insensitivity, we all agreed on. We did not agree on the more subtle forms of mistreatment, aggressive questioning, feedback, and assignment of tasks. And then the funny thing is that when you looked at the severity rating, we didn't agree on the severity rating, and I shared you one. I'm going to show you more in just a little bit. And the one other point that I want to emphasize is very important. Prior mistreatment sensitizes us. People who are mistreated not only are more likely to become burnt out, but they're more likely to perceive mistreatment when it happens again. And it's a vicious cycle. People who have been mistreated become more likely to mistreat themselves. And the literature shows that if you're burnt out, you are 2 to 3-fold more likely to commit unprofessional acts. So mistreatment cuts both ways. So here's the data that I was referring to. We all agreed on sexual harassment and ethnic insensitivity. That's mistreatment. But we did not agree on aggressive questioning, inappropriate tasks, and negative feedback. And the other scary thing is when you looked at the severity of perceived mistreatment across the specialties, the 3 most obvious examples, the negative feedback one I showed you, the sexual harassment one I showed you, or aggressive questioning and the sexual harassment, and the ethnic insensitivity, the 3 most obvious forms of mistreatment, we did not agree on the severity. And again, if we don't agree on the severity, we might be less likely to actually report the event. So in conclusion, what I'd like to close with today is mistreatment is common. Mistreatment varies depending on what your gender is, your ethnicity, and your professional role. We found in our study, professional role and specialty and prior mistreatment did influence perception of mistreatment. We did not find that gender or ethnicity did. And as I've already alluded to you guys or discussed, it's deleterious both personally and professionally. Our perceptions vary, and we gotta stop mistreating others. And we must come up with ways of not internalizing mistreatment. And you gotta just realize sometimes, and I'm just gonna say it, I know it's grand rounds, but shit flows downstream. And you need to think of it more as that it's the other person's problem and not yours. Don't internalize it. Something's wrong with them for acting the way they are acting, and it's not necessarily you. And if there are behaviors that you're doing that other people keep saying you're doing, fix it. Don't ignore it. If many people are telling you those things, you need to fix that problem. And we really need to come up with creative solutions for patients, families, and visitors. Because that, I think, is the white elephant in the room. What do we do with patients, families, and visitors? And the bottom line is it's going to take a village. And I'll stop there and open it up to any questions. Thank you.
Kevin, I have a question.
Yes.
It would be very interesting to me to see this broken down by age. When I watched the scenario of the attending residents and students, it reminded me very much of medical school, which is certainly not what we do today. Do you have any data on the age and their perceptions of mistreatment?
I have the data. I haven't analyzed it, but we looked at age as well, and we looked at how many years you were in the role, were you previously mistreated. So yes, age, we have that data. I have to analyze it. And I also have to analyze it as if you rated it less severe, are you less likely to report? Because I think that's another important question.
Yeah, be sure to show it to me when you get it, or tell all of us. This is
Yeah,
a great
no,
talk.
I need to analyze that data. I just got to find the time. Any other questions? And the data set has like 9 papers in it, easy. I just got to find the time. Please feel free to ask questions, anybody. Let me see if I can pull up the chat, because there might be questions in the chat.
There's nothing in chat right now.
Oh, okay. Either nobody has comments or I put everybody to sleep.
Or you were very clear.
All right, one last thing that I'll share with you guys. So what are some solutions? What are solutions to this problem? What we're doing today. I really think we need to discuss this and have open, honest communication. And I'm telling you, I do this in small groups, not over teams, but in groups. You'd be amazed at the honesty in the room when you show these videos. I've had attendings come up to me and describe events that happened to them when they were students, and they did so publicly as well. So doing what we're doing today is important. Implicit bias training. We all have biases. We are all demonstrate partiality. Please don't let any one group say they are impartial. They're not telling the truth. We all have implicit biases. And if you've ever been to one of those sessions, you'll figure out real fast you've got them. Leadership courses, I think, are important because the behaviors are, leaders can't do certain things. Bystander training. So what should bystanders do about this? Anonymous reporting, like ethics point that I shared with you guys today. And then the other thing that we need to do as a group, as a hospital, as a practice plan, is have patient rules and regulations that have teeth. I have patients that are so inappropriate and I can't fire them. And yet they still do some behaviors, and it's like, it takes an act of God or Congress to get them fired. And, you know, if they're undermining the morale of our trainees and steering trainees away from doing internal medicine, they don't need to be followed by us. And we really need to put teeth in our bylaws, if you will. And with that, I'll stop there. Thank you for your attention.
Kevin, this is Shanu. May I make a comment and maybe a question?
Yes.
Thank you for a fantastic talk. I think they say 72% of drivers claim they're above average, and I'm one of them. And I would love to have, I think we're often not aware of our behaviors, right? Sometimes we are, but sometimes we're not. I would love to have some sort of peer observation and mentorship and feedback just to open my own eyes. As you mentioned, a lot of times we have implicit bias against others, but I think we probably have implicit bias towards ourselves too.
I totally agree. And in the wise words of Groucho Marx, there are two types of people in this world, and I'm one of them. And I think we have a tendency to not be self-aware. And I think peer-to-peer evaluations, peer-to-peer observation can be powerful. I love what I do at the VA on Fridays because I actually get to work with the attendings. I'd love for the attendings to give me feedback. That would be fine. But at least we get to work together, and I get to see us team teach and the different approaches to the care of the patient. And I think it is rewarding. So I totally agree with you, Shanu.
Kevin, thank you very much for a superb grand round. How current, how appropriate. Thank you very much. Great job.
Thank you, sir. Have a great day.
Thank you.